Good morning.
Good morning.
Morning.
Just wait a second and get going. All right, so this is a somewhat short conference, but good nonetheless. Okay, this is a tracing from a 10-day-old following urgent C-section for elevated fetal heart rate. And this is the electrocardiogram that was obtained. So the question is, what is the diagnosis and how would we treat this? I think I'm going to ask, here. I'm gonna ask Dr. Bebbia what he thinks about this tracing.
Good morning. So we can see that the P wave in 1, 2, 3 AVF is negative. So this is not sinus rhythm. This is low right atrial rhythm. Our heart rate is about 170, I guess. It's regular. QRS is narrow. Axis is indeterminate. And I don't see any signs of RVH or LVH. And T waves are non-specific, I would say. So 10-day-old and a heart rate of 170. I mean, I don't think that's very elevated. I think it's still within normal range for a 10-day.
In sinus rhythm, yes.
I see. In low right atrial rhythm.
And you're saying this is low right atrial rhythm because of the axis of the P wave, is that right?
Yes.
But okay, so why don't we use terms for arrhythmias that we're more familiar with than low right? I don't know that you and I have ever had a conversation about a baby in the PICU or NICU with low right atrial rhythm. Is that a term we've ever used before? I don't think so.
We would probably use ectopic atrial rhythm or ectopic atrial tachycardia.
That's one possibility. That's certainly in the differential. Anything else that could be in the differential? What is the QRS to P wave interval in this patient?
It's long.
Very long, right? Like how many milliseconds is it about?
So it is at least one big box.
So it's at least 200 milliseconds, right?
200 milliseconds. So PJRT.
Yes, it could be
the diagnosis.
It could be PJRT. Now, is there anything that would? So you're right. The differential of this would be either PJRT or ectopic atrial tachycardia. So is there anything about this tracing that would push you in one direction or the other? You would get full credit for saying one or the other, but if I forced you to say which one is it most likely, or alternatively, if you don't know the answer to that, is there anything you could do provocatively to prove it's one or the other?
Try giving adenosine.
What would happen if you gave adenosine and the patient had ectopic atrial tachycardia?
So we will block the AV conduction and basically we would well, we would see the atrial ectopy still.
That's one possibility. And what if it were a PJRT? What would happen if you gave adenosine in that setting? Tell me the circuit of tachycardia in PJRT. Is PJRT automatic or reentrant in nature?
PJRT is reentrant.
Correct. And so what is the antegrade and what is the retrograde limb of the tachycardia?
So it would be
how do we go from atrium to ventricle in a patient who's in tachycardia with PJRT?
yeah, we're not going through the oh, actually we are going, no, we're not going through the AV node.
No, that's not true.
We are going through the AV node.
We are going through the AV node. What is PJRT? So in PJRT, we go from the A to the V through the AV node. And how do we go from the V to the A?
Through an accessory pathway.
Right. And what's special about the accessory pathway in people with PJRT?
That it's slow conducting.
Right. Very, very slow conducting, which is why the R to P interval is so long, right? We have an RP. You said that the RP interval is over 200 milliseconds, which is correct. It's probably more like 270 or 80 milliseconds in this case. So, so if you gave adenosine to somebody who's in PJRT, what would happen? Now that we know the two mechanisms of antegrade and retrograde conduction.
Then you would conduct antegrade through that accessory pathway?
No. PJRT pathway is only a retrograde conducting only. So you would block in the AV node, you would have a pause in tachycardia, but then tachycardia would resume. And I'm going to now flip to Grace Kong and ask you, Grace, why would tachycardia resume if I gave adenosine and it blocked in the AV node, causing tachycardia to terminate? Why does it usually restart again?
In PJRT?
Yes.
I mean, if there is another event that causes there to be, or actually, because I'm sorry, it's a slow conducting pathway. That's why, because it's a slow conducting accessory pathway, and usually in reentrant tachycardia, if you have one fast and one slow, that kind of sets up the loop. So in PJRT, there's already that condition.
Right. So that's correct. So, you know, the question that always comes up, or that I used to think about when I was younger, was if somebody has an accessory pathway, like a regular accessory pathway, like a concealed pathway, the question is, why is the patient not having tachycardia 24 hours a day? Right? Because theoretically, you should be able to go. So when you're in sinus rhythm with a concealed pathway, you go down the AV node from A to V, and then you go back up from V to A through the pathway, right? Every single time a person is in sinus rhythm and has a sinus beat, but they have an accessory pathway, they are going from A to V, but they also are going through, the pathway is trying to conduct from V to A, because when the ventricle is excited, it will naturally go back up the pathway. Why is it, go back to Sergey. So why doesn't a patient just go back into SVT every single time? Why is there not reentry all the time in a regular pathway?
Because of the refractory period, I guess.
Of what?
Of this pathway.
No, it's of the atrium.
Oh, eight of the atrium, right.
Right. So normally we say that an RP interval greater than 70 milliseconds denotes usually an accessory pathway, whereas less than 70 milliseconds is the AV node. And most accessory pathways have an R to P interval of like 100 milliseconds or so. So in the time it takes to go from A to V and V to A, the atrium is still refractory. And so that's the reason why if you have an accessory pathway, you're not in SVT all the time. And that's because you are going down the AV node, but then you're coming back up the pathway so rapidly that the atrium is still refractory because you just had a sinus beat. The difference in PJRT is that the pathway, as Grace alluded to, the pathway is so slow in its conduction characteristics that you go down the AV node, but then the pathway conducts up so slowly that by the time it reaches the atrium is no longer refractory, and you therefore depolarize the atrium and then go back down the AV node. So by definition, PJRT causes a slower than usual tachycardia than you would see with a normal concealed pathway, because by definition, the pathway conducts slowly. So paradoxically, even though it conducts slower, you have more sustained tachycardia. And this is why it got this misnomer of permanent form of junctional reciprocating tachycardia, because it seemed to the people who were naming it as if this tachycardia was permanent. It just never ended because there was always conduction up that pathway allowing for reentry. And this is why these patients develop tachycardia-induced cardiomyopathies, because they are constantly in and out of tachycardia because of this. The other thing that goes against this being EAT is the relatively normal or even short PR interval. Now, you can't hang your hat on this, but most of the time when someone is in EAT, their PR interval is long. They often have first-degree heart block when they are in tachycardia. This patient clearly does not. And then the last thing that goes with it being PJRT, although it still could be EAT, is the fact that, as you said at the beginning, Sergey, you have these inverted P waves in the inferior leads, which suggests it's in the posterior septal region, which is the most common location that PJRT pathways are located in. So if we're going to guess what this was, we don't know for sure. I would say this is probably PJRT. And so if we gave adenosine to this patient, we would see transient termination in tachycardia followed by resumption of tachycardia almost immediately. And so this is a good example of why it's very important always when you're giving adenosine, if a patient is stable, to run the electrocardiogram, because in someone with PJRT, because of the extremely slow retrograde conduction to the pathway, you can literally go back into tachycardia within one beat of termination. And in real time, it may seem as if you never terminated tachycardia, but in fact, you may have. So it's always important, if you have a stable patient who's stable enough to get EKG leads on them, to try and run the tracing while you give the medication. In this case, the other thing I would say is that you were absolutely right, Sergey, that normally if this were EAT, we would expect that the primary atrial arrhythmia would persist and there would be heart block transiently from the adenosine. But some EATs are adenosine sensitive, at least transiently. So it's a helpful maneuver, but it isn't necessarily going to give us the diagnosis. It's nice if it does block the AV node and the tachycardia persists, but sometimes adenosine will cause the EAT to terminate as well, at least transiently. Okay, so you have you call to the NICU about this patient. They are in tachycardia, although not very fast. And as Sergey correctly said, this heart rate of 170 is not, especially worrisome in the short term. But Grace, what would you recommend if the NICU is asking you, they're saying that the heart rate is pretty much sticking around 165 to 175, and this is the rhythm most of the time. Does this need to be treated? And if so, how would you treat it?
Yes, I would treat this patient. I
Why would you
say
treat it?
for the long-term effects of 170 isn't going to make the patient sick, but it is tachycardia. So I would treat this patient.
And over long periods of time, it will actually make the patient
Right.
sick. You know, it's fine to be 170 for half an hour here and there, but it's not fine to be 170 24 hours a day. You know.
Mhm.
Okay, so how would you treat this?
I think beta blocker. Are we calling this? We're not sure yet if this is EAT or PJRT.
I
Correct?
think we would probably say it's probably PJRT.
Probably PJRT. Yeah, I think I would probably still start with the beta blocker.
Okay, so
Okay.
you've given beta blocker, you're now up to 3 per kilo. You're still not, tachycardia rate's a little slower. It's like 160 now, but you're still spending a large part of the day in tachycardia. So what else could you do?
I'm only going to consider oral agents for this patient. So I think I would next go to amiodarone.
Amiodarone, very aggressive cardiologist. Okay. Yes, amio could potentially work.
Break.
Let's say the mother calls you, says, Dr. Kang, I just went online and Google says this is a very dangerous medicine. I don't want to use this in my baby. So you explain that it's only short term, but they say, no, I don't want this toxin in my child's body. So what would be an alternative?
Sotalol.
Right, you could use Sotalol. That's true. What else could you use potentially?
PJRT. Flecainide.
Yeah, flecainide you could use for this as well, or propafenone. Yeah, flecainide could be very effective for this. I actually probably would start with flecainide for this. Mostly because it's very good at blocking accessory pathways, and it oftentimes will be effective. It's also possible that you could take a person who's intermittently in tachycardia with flecainide and make them permanently in tachycardia by slowing but not blocking completely pathway conduction. And as you know, I'm always afraid, and we should always be afraid of flecainide in babies because it has to be compounded, and sometimes there's quite a bit of dose variability based on that. So I'm saying flecainide. In a perfect world, flecainide would be my choice, but probably, honestly, I would go with Sotalol. And based on this recent data from Texas, I would rapidly elevate the dose up because in my experience, Sotalol is not as effective at the lower dosing range of like 80 to 120. Often have to go a little higher for a drug, for a arrhythmia such as this, but that's probably what I would do. All right, enough on this case. Good job. Let's go to the next one. All right. This is a patient who is in tachycardia. And question is, what is the mechanism? I am going to ask Dr. David Barris what he thinks.
All right, let's look at which leads we have. We have the surface leads and IRA, and then we have a His catheter with a large His, and then we have CS7, 1 through 8. Let's see. So we're in tachycardia right now. Is that what we're saying?
We are in tachycardia, and this is not labeled very easily. This is CS proximal going down to CS distal, and this is an octopolar catheter. So it has, instead of what I normally use, which is 10 pairs, I think Barry normally uses an octopolar. So this is like a case with Dr. Love. So this is distal, proximal, right ventricle, and as you said, His, high RA, and 3 surface electrocardiograms in tachycardia.
So I'm looking at our CS catheter, and it looks like we're earliest in CS 1-2. So that would be eccentric conduction, indicative of a left-sided pathway.
That's right. That's
So
exactly
it would
right.
be reentrant with so an accessory pathway that's left-sided.
That's right. So we have, so again, when you're looking at these tracings, we look first at the surface electrocardiogram. So here's the QRS. And so anything on the tracing that is simultaneous with the QRS is going to be the ventricular electrogram. So come down here, there's no ventricular electrogram on the high RA. This is the atrial electrogram on it. We see that the R to A wave is very long. It's certainly over 70 milliseconds. This is the V on the His. Here are the V's in the coronary sinus. And David, you correctly pointed out that the earliest V on the coronary sinus is actually in the distal pair, not in the proximal pair. So normally, if we were going up the AV node, we would expect it would be the opposite depolarization pattern to what we're seeing here, with the earliest being in the proximal CS, the latest in the distal CS. So this eccentric retrograde conduction is consistent with the presence of a left-sided accessory pathway, either concealed or WPW. Is there any way, David, to tell from this tracing if this is WPW or a concealed left-sided pathway?
So if we're in tachycardia, then I mean, because if we were not in tachycardia, we saw pre-excitation, then it would not be concealed. So we're in tachycardia right now. So
right. So can you tell in tachycardia if it's concealed or if it's a WPW pathway? I think you're almost about to say the right answer.
I guess not.
Yeah, you can't tell. You cannot tell in tachycardia if the patient is WPW, not because the accessory pathway is conducting retrograde in tachycardia, and antegrade we're going through the AV node. So until tachycardia breaks, you would not know if this is concealed or a manifest pathway. And we see here that there's a little arrow here somebody drew to point out the presence of the retrograde P wave in the distal coronary sinus as the earliest. So this is correct. This is a so-called eccentric pattern, suggesting that it's coming far from the AV node, left-sided. So we would have to do transeptal, or alternatively go retrograde, cross the aortic valve, and retroflex the catheter back over to the left lateral position. This is a position that, there's debate. Most pediatric electrophysiologists in the United States would do this transeptal in 2022, but there still are a number of centers that would do this retrograde. Actually, the group in Stanford, a lot of doctors there would still do this retrograde. But what I am told, and I don't do very many retrograde accessory pathways, maybe one every 5 years, but I'm told that the left lateral position is harder. Most people who can do both routinely will say that this is an area that is a little bit harder to reach retrograde than antegrade, and opposite pathways that are in the proximal area on the left side are a little easier, they say, going retrograde than going transeptal and then turning the catheter around a very large angle to get back to the area of the pathway. Okay, very good. Good job. All right. This is a 2-year-old who had a febrile seizure. This tracing I saw online from a website called Life in the Fast Lane. And I'm going to ask Dr. Zawani for your interpretation of this tracing in a 2-year-old who had a febrile seizure.
Okay.
And is now fine.
All right. So start with the lead one. So we have a upright P wave in 1, 2, 3, and AVF, but looks like I think the PR interval is, yeah, it's long, right? Maybe like around It's getting to
A little
like
less,
5.5.
I think it's a little less than 200 milliseconds, maybe
Yeah.
just at 200. So it is longish. I'm not
Mhm.
disagreeing. No.
And then let me see. So I think looking at P1, there's a looks like RSR prime.
Mhm. Yeah, I agree.
And yeah.
So this is a bit of a
Mhm.
tricky KG. There's actually nothing especially wrong, except for the first degree block that you noted,
Mhm.
Terrence. Every once in a while, I like to throw in a normal just to freak you out a little bit. Now, what about the RSR prime? Does that worry you at all in lead V1? Is that a normal observation, abnormal? What do we think about that?
Yeah, I mean, yeah, most of the time, like it could be normal, but sometimes, like if we see it, like if the physical exam could be leading, if you have like suspicion of ASD, sometimes you can see it with it.
Yes, that's true. I mean, I was taught, people have different views or thoughts on this. I was always taught that RSR prime in V1 is a normal observation. I think most people believe that. And I would not call it a so-called incomplete right bundle branch block unless I saw it also extending to V2. That's sort of what I was taught. I don't know that that's right, but so in this case, I would probably not even comment on it if I were formally interpreting this tracing, but I would probably comment on the PR interval being in a 2-year-old, this would probably be right at the level of first degree heart block. If you saw a patient, Tarek, with first degree heart block, what kinds of things are you thinking about in terms of etiology?
Yeah, so I think 2-year-old, like you will start probably with some basic labs, and then I'll think also about Lyme disease too.
Yeah, what else?
And then we'll see if there's any history of the mom having Sjogren disease. I mean, even it's a long stretch because it's more like a complete heart block. So
Yeah. What about can the thyroid gland have any impact on nodal
yeah,
conduction?
hypothyroidism too.
Hypothyroidism. Also, you'd want to get a SED rate or a CRP, right, to make sure that there's not inflammation, especially if patient had a seizure. But this tracing is pretty close to normal. So, okay, we'll do one more. Okay, so this is a tracing. This is a 13-year-old who presents to the emergency department with palpitations and near syncope. What is the diagnosis and how would we treat this? I think I'm going to go back to Grace Kong of Texas. Your thought on this?
So I'm looking at the sneaky full EKG, looking at the tracing at the bottom. Oh, looks like ventricular tachycardia.
So is it wide or narrow?
It is a wide tachycardia.
And is it regular or irregular?
It's irregular.
And is it regularly irregular or irregularly irregular?
It is irregularly irregular.
So what do you think this is?
AFib with RVR, rapid ventricular conduction.
Yeah, that's what this is. This is probably a patient who has WPW who's having atrial fibrillation. So you're in the emergency room and the patient is talking to you. They're in the stretcher. They don't feel great, but they are able to talk to you. What would you do for this patient?
Mm-hmm. They're talking to me. I could synchronize cardio with the patient.
Okay, how would you practically do that? So
Gives
you're
a
in
little.
you're in the ED. The patient's talking to you. They
Mhm,
haven't eaten for 3 hours, we'll say.
mhm.
What would you do? So first of all, what
Yeah,
dose would you give the patient?
1 to 2 joules per kilo.
Right.
0.5 to 1 is the correct answer, but
Right. Probably give about 1 per kilo because remember, we're treating atrial fibrillation, not ventricular fibrillation.
mhm.
And does this patient need anything else other than the pads and the correct dose of medication?
Will the patient be able to tell me when they went into tachycardia?
They felt it about an hour or two ago.
Mm-hmm. No, I think I can safely cardiovert this patient
Okay,
with
so the patient's
sedation.
talking to you and you've now got the pads on. Are you going to just tell the person next to you to charge to 50 joules in this 50 kilo child, or
No, I would give a little bit of sedation.
would you give a little bit or a lot? Do you want them to
Um,
be awake at all, or?
no, not awake, but not enough to suppress their respiratory drive.
Right, so they need to be fully sedated, that's
Mhm.
a very important point. I didn't kind of realize how important this was. But the bottom line is, in somebody who's awake, we never, ever, ever shock anybody unless they are unconscious. And so if they're unconscious from their arrhythmia, then you can just go ahead and shock them without any sedation. But if they are awake in any way, you have to sedate the patient. It is cruel to not do that. Yes, this is absolutely an arrhythmia. What are we worried about with this arrhythmia? What could happen from this, Grace?
They could degenerate into a ventricular.
Right, they could degenerate into VF because the
Mhm.
ventricular rate is so fast and it's so irregular that you could have an R on T and just boom, go right into VF. Now, if they went into VF, they would become unconscious. But in this rhythm, the patient is still able to talk to you, albeit, at any moment they could go into VF. So there is definitely an urgency here for sure. But it's very important to remember that we should never be cardioverting or giving any electricity to some human being without them being unconscious. And that means either that they're unconscious from their arrhythmia, in which case you don't have to sedate them, just go ahead and shock them. And, in PALS, when they teach you about, which rhythms are shockable, the assumption is the patient is arresting. That's, you're doing CPR, et cetera. But in a patient who's awake, the fact that you're doing it quickly because you're afraid that something bad is going to happen is not an adequate rationale to do it without sedation. We never ever shock someone who's conscious. Okay, so you would either ask the emergency room to give them something, or you would rapid call for the anesthesiologist on call to come down rapidly to help sedate the patient. But we wouldn't, for example, like give 2 milligrams of morphine and say, well, it won't hurt as much. Believe me, it will hurt a lot. And the patient will not like you or thank you. You would have saved the patient's life, but they will not thank you for it, fortunately. And would this be synchronized or asynchronous, Grace?
Synchronized.
This would have to be synchronized, right? Because
Yeah.
if you put it at the wrong time, you could hit a T wave, and which is, it's not intuitively obvious, right, that this would be synchronized because it looks like VF, but it's really rapidly conducted AF. And so we would want to be careful to deliver it. The other thing I would remind you is that because the rhythm is irregular, before you deliver the shock, you want to make sure that the computer can sense properly. It may not be able to sense all the QRSs, but it should be sensing most of them. And the other very important thing is that once you press the button, it's going to wait until it is confident that it sees a QRS before it delivers the shock. And that might be 2 to 4 seconds after you press the button. So never, ever, ever touch a patient for a synchronized cardioversion until after the shock has been delivered. Sometimes you press it and you're like, why isn't it not shocking? It could sometimes go on for 5 or 10 seconds. And one of the biggest mistakes you could make is to go touch the patient and see if the pads are not touching the patient, because that's exactly when the device is going to go off. So if you press the button and it doesn't deliver a shock and you're not sure why, and it's been a long time, turn the machine off. Then you can figure out what's going on, or turn off the defibrillation part of the defibrillator. Then it's safe to check. All right, and with that, I think we'll stop. Thanks very much for joining. Next week, I will have come back from the Heart Rhythm Society meeting, and I will give you the talk that I'm giving there on how many PVCs is not acceptable in an ACHD patient. So, all right, everyone, have a great week. I'll see
Thank you.
See you on Sign Out.
Thank you.
Thank you.
Bye-bye.